It's my pleasure to welcome you to Nourishing Generations, Maternal and Child Nutrition. At this time, I'd like to introduce our session chairs. Naomi Seville is a Principal Research Associate at the University College London Institute for Global Health. She has 35 years of research experience, mostly on maternal and child health and nutrition in Nepal. Please put your hands together for Naomi. Insering Lama, PhD, is a Johns Hopkins Bloomberg School of Public Health's Nepal country representative, and she is an epidemiologist with 13 years of experience in maternal, child, and newborn health research. It's a pleasure to have you here with us. Thank you very much. Without further ado, over to our session chairs to take us through this session. Thank you very much.
Okay, good afternoon, everybody. I know it's the after lunch session, but it's the last session for the day. Oh, maybe I should stand up. I was like, it's our pleasure. As you know, Naomi and I, we both work in the field of maternal and child nutrition. So it's our pleasure to welcome you all to this last session. The session is called Nourishing Generations, Maternal and Child Nutrition in the Context of South Asia. Today we gather to reflect on one of the most urgent and yet profoundly hopeful challenges in our region, ensuring that every woman, every newborn, and every child has the opportunity to thrive. So South Asia, as we all know, carries a significant share of the global burden for maternal undernutrition, low birth weight stunting, and micronutrient deficiencies, as we've seen over the past 3 days, including today. And these issues are not just statistics. They affect the health, dignity, and potential of millions of families. So at the same time, the region is also home to innovative research, community-led interventions, and policy advances that shows us that progress is not only possible, but also underway. And I'm sure we have 6 very exciting presentations. Power of locally adapted innovations, cross-sector collaborations, and system-wide integration in shaping the healthier futures for the next generation in our region. So the insights shared today have the potential not only to inform programs and policies, but also to transform lives. So as you know, we'll be taking questions at the end. So as the interviewers finish, please note down your questions. And then I think we have like 15 to 20 minutes in the end for questions. So I'll just end there. And so I think I will start first with the first presenter. Our first presenter is Neeta Shah. She's from the Center for Health, Education, Training, and Nutrition Awareness. She'll be presenting on reducing nutritional anemia via health education supplements, iron-rich diet for women, 19 to 45 years in Madhya Pradesh, India. Okay, Neeta ji.
of Ratlam district, Madhya Pradesh state, India. We work in the 20 villages which are Second was the capacity building of the stakeholders, particularly the frontline workers. And this was done on the behavior change communication and the counseling skills. Third and important was the stakeholder engagement. There was the collaboration at the grassroots level with the local NGOs, CBOs, panchayat members, circle members, and with the government health officials at the block level and the district level. Toward the intervention and to promote the anti-diabetic practices. Before we started the intervention, we had done the baseline survey. Now, the baseline survey was done by visiting each and every household of these 20 villages. The women were interviewed on the socio-economic status. We had collected data on their knowledge on anemia, their dietary practices, their reproductive history, and their access to healthcare services. And to our surprise, we had found that many of the women during the survey say that it was the first time that they had undergone their hemoglobin checkup and they had never heard anything about the anemia. And also the data shows that 71% of the women whom we had interviewed and also during the baseline we had done the regular checkup and it was done through a digital machine. So what does the data say that 70% of our intervention here women were there was very poor or almost no knowledge about the dietary consumption, about the population activity, particularly the restriction of dietary supplementation under the government schemes. Also there was no consumption of dietary pellets and absence of nutrition diversity in the area. So then what we did? The intervention was done with the dedicated women at the field level who had visited this women on a regular basis. These women were given the information on the dietary practices about the anemia knowledge as the distribution was done regularly and there was also tracking of the age. 6 months they were delegated on the age checkup and also they had given the anemia card. So this anemia card has the information on what are the symptoms and we had also tracked on what the symptoms they are facing. Secondly was demonstration of energy food. This had helped us to show the sustainable approach. The dietary food like we had demonstrated on beetroot paratha, sprouted pulses milk and the date laddu. Very important was the use of moringa leaves and also the use of iron vessels. Now, for a woman to act upon, there was also the support of community is very important. So through the mass awareness activities such as wall painting, puppet shows, and street plays, we had tried to create a supportive environment, address the cultural barriers, and build a collective commitment from the health aspects. Strengthening of the frontline workers' capacity also helped us to get their support throughout the intervention. Also, it has enhanced their skill on communication and counseling, and also improved their knowledge on anemia. Regular sharing and meeting was very important. Here I would like to acknowledge the government support. Throughout the intervention, we have received the government support because for the referral mechanism of the severely anemic woman to the district or for the block for the iron sucrose or the blood transfusion, government has always supported us. Also, the uninterrupted supply of IFPRI. Even after the intervention, the government has done a lot of efforts, and even after 1 year, we could see the anemia prevalence had shown a good improvement. As I shared that sharing and regular meetings has also helped us to showcase the improvement. Now about the results. I forgot to skip this slide, but anyways I had discussed what interventions we had done. Now about the results. How we had done this, as I said that the baseline was done, tracking was done, HB test was done every 6 months, and the knowledge assessment was also done every 6 months. We had an application through which the data was collected. And at the end of the 2 years, what we see that the anemia prevalence had shown a significant change. Like the woman at the baseline, 29% had a normal hemoglobin, which has gone to 54. Moderate anemia has reduced to 9%, and severe anemia, none of the women were severely anemic at the end of 2 years. Again, the IFA consumption was very important. More than 50% of the women had consumed more than 180 IFA. Again, she's showing me this slide, so I would like to say that wherever we had analyzed further data, the women who had increased knowledge awareness has also shown an improvement in their anemia HB status. This is the tremendous improvement in the knowledge. As I said, there was individual counseling, group sessions, and the awareness activities. Basically, what we had learned is the community engagement is very, very important to show the success of any of the project. Integrated approaches are very important to show the result and the local leadership. Here I would like to say that we have to treat family as a whole. A woman cannot take any decision individual on her own. So right from the beginning, we had involved the husbands and the elderly women of the family so that they also know about the situation, the condition, and all the baseline and the endline difference. We have seen that women themselves said that their hemoglobin has increased or not, but there was lot of improvement in their overall physical health. Like before they used to skip the meals. Now at least they had at least 2 meals in a day with a regular use of the moringa powder and at least dates use at least once in a week. So these are the very important results which we have got, we have tried to find out from the field. And lastly, for the long-term sustainability, as I would like to say that community ownership is very, very important. Strategic planning, partnership and the government involvement to integrate the anemia prevention in the existing services. Capacity building of the frontline workers is again very important. Evidence-based monitoring, robust monitoring data, like each and every day our team used to go to the field and collect the data, and this data-driven results we have able to show. And last not but the least, but the individual and family level awareness about the anemia is non-negotiable for long-term sustainability. Thank you. And also I would like to thank each and everyone. My Chetna team is here and the field team who had without the any tiredness, dedication, they had been able to help us to bring this result and fund us HDB Financial Services. Thank you.
Thank you, Neeta. That was fantastic, very interesting, and so important to see the importance of the engagement of the husbands and the community there. I'd like to next invite Dr. Rajni Om Prakash Vadva from Plan International. She's going to present on Mum's Plate, community-based cooked meals support to improve maternal nutrition. Welcome.
And I'd also like to just give a friendly reminder. I know that we're coming from lunch, so just try to keep your side chat. If you need to have a phone conversation or anything, just please leave the venue just out of respect for the presenters. Thank you very much. Over to you, Rajni.
Good afternoon, everyone. I'm Dr. Rajni Vadva from Plan International India Chapter. Very delighted to be here presenting at this forum. At the outset, let me also acknowledge the contribution of my co-authors, Mr. Mohammad Asif, Mr. Somen Ghosh, Baljit Kaur, and Kulwinder Mahmood. Today, I want to share with you a solution that is simple, community-rooted, and deeply aligned with the D4N priorities. It is called Mom's Plate, hot cooked meal support for improving maternal nutrition, while simultaneously also strengthening women's economic empowerment. So this initiative emerged from a very basic question. If we know that the pregnant women require nutritious food and more nutritious food, why are they still not getting it? We know that pregnant women require around 300 to 500 extra calories per day. In India, many women, especially those from marginalized households, eat last and eat least. What we are facing is that 52% of pregnant women are anemic, 18% have low birth weight babies, infant mortality is high at more than 35 per 10,000 live births, and although India's integrated child development services system provide the take-home dry ration, many women don't consume them, either due to the taste or they're culturally not acceptable, and mostly it is shared within the household. So poor maternal nutrition drives a chain reaction. Low birth weight, stunting, increased neonatal mortalities, and intergenerational undernutrition. So we asked, can we transform the nutrition access from the ration distribution to a meal consumption model? And this question shaped the Mom's Plate project. Our approach involved 4 interconnected pillars. We identified and assessed the pregnant women at nutrition risk through the Anganwadis and the community workers. We registered the high-risk pregnancies and mapped them for anemia, low BMI, and other vulnerabilities. We also empowered the local women entrepreneurs, trained them in safe quality cooking, financial literacy, menu planning, and supported them to secure the Food Safety Standards Authority of India's registration. Now this created a sustainable local service ecosystem for maternal meals. We also worked on strengthening the family behaviors. The speaker ahead of me also talked about this, where we provided counseling on diet diversity, hygiene, rest, danger signs, and also highlighted the importance of involving the male family members and the elderlies into supporting the maternal care. We digitally tracked the progress, used a simple mobile technology. We monitored the daily meal deliveries, weight, blood pressure, hemoglobin levels, pregnancy progress, and referrals to the health systems. And to reinforce the dietary diversity, we promoted kitchen gardens to make iron-rich, vitamin-rich vegetables more accessible. So our delivery model, how did it work? So we worked alongside the government Anganwadis to identify the pregnant women. The local women entrepreneurs prepared the meals, which were nutrient-rich, locally sourced, culturally acceptable. The meals were tracked digitally to ensure that they are actually consumed, and the nutritional counseling is offered to the mother and the family. This aligns directly with the key government priorities. So sustainability is very important to align with the local government priorities, ICDS supplementation goals, the Portion 2.0 and the Portion Tracker. These are the schemes by the Department of Maternal Health and Nutrition. National Health Mission talks about the maternal health outcomes, so we align there, and SBCC to maternal nutrition practices. There was a very strong equity lens. We prioritize women from the poorest households, the adolescents and pregnancies, the socially excluded groups, and the high-risk pregnancy. So in short, the program ensured that the women who need nutrition the most do not slip through the cracks. Our key findings over the years, we cater to more than 815, and as I talk, the number has further increased, malnourished pregnant women across 2 districts in states of Delhi and Rajasthan of India. We prioritized and provided around 50,000 hot nutrient-rich meals. These were carefully designed by the nutritionist. These meals acted as a top-up to the ICDS take-home rations. And now the outcomes. 93% of the newborns were born with normal birth weight. The normal hemoglobin doubled. It was earlier at 46. It reached 88 women. Severe anemia was almost eliminated. No cases of severe anemia were reported. Preterm births also reduced 7.2% from 7.2 to 6.9. Underweight pregnant women dropped dramatically. 87 pregnant women who were underweight earlier dropped to 38, and the normal BMI increased by almost 24 to 25%. Most importantly, the women empowerment became a billion benefit. The local entrepreneurs were now earning around INR 17,000 per month on an average. This increased their dignity, visibility, and decision-making power. So if I talk about the significance of this Mom's Plate program and application, why did this model work? Because there was consumption and not just provision focus, ensuring women actually eat the nutritious food. The early risk detection, enabling health referrals before a pregnancy became complicated, and women-led local enterprise, reducing dependency on externally funded supply systems. So all in all, what we realize is sustainable, cost-effective, and complementing the ICDS and the National Health Mission, strengthening both nutritional outcomes and community systems. And for South Asia, where households, food sharing, gender norms, and resource constraints affect the maternal nutrition, this model provides a practical, evidence-backed solution. Talking about systems and partnerships to scale up, the scale, I think the systems thinking is the key. And we integrated with the government's ICDS and portion supplementations. We aligned with National Health Mission's referrals and follow-ups. We involved the Panchayati Raj institutions for referrals and local ownership, primary health centers for clinical monitoring, and self-help federations to empower and entrepreneur trainings, digital health platforms for real-time monitoring. Community ownership, as we know, reduces long-term costs, and women entrepreneurship and also ensures continuity. So lastly, to conclude, Mom's Plate is not just a nutrition intervention, it is a system solution, and it brings together the nutrition access, behavior change, digital accountability, women's economic empowerment, government alignment, and equity for the most vulnerable. Thank you, and I look forward to collaborating with many of you to take this model forward across South Asia. Thank you.
Thank you, Rajni. It's definitely, as we saw from the evidence, that it is working, and it's a sustainable model. And I like the fact that you're using local women social entrepreneurs to also make this sustainable. And I think we could apply that in other countries and states. So next, I would like to invite Santhia Irene. She's representing from BRAC, James P. Grant School of Public Health from BRAC University. She'll be presenting on the feasibility of implementing community-based maternal, infant, and young child nutrition and primary health care package in Bangladesh.
Thank you, and good afternoon, everyone. And today, I'm going to discuss about the feasibility of implementing an integrated community-based approach where the interlinked maternal, infant, young child nutrition with primary health care was tested by the government system. If you were present in yesterday's keynote speech by Dr. Hamida Ahmed, you could see that we have made a tremendous improvement in terms of reducing stunting. We have improved stunting from 56% in 1996 to 24% in 2022. A lot of effort has gone in to fight this daunting level of stunting in Bangladesh. The government of Bangladesh started a vertical nutrition program in 1996 with support from World Bank. But even after implementing for more than a decade, the coverage was very low at only 25%. And in 2011, the vertical approach was disbanded, and we moved forward with a more mainstreaming approach, and nutrition services were embedded. Rather than a vertical approach, the nutrition services were embedded in the routine primary health care services of the health and family planning. And there was also it was also envisioned that the existing community level workers will be capacitated progressively to deliver mainstreamed nutrition service. However, despite mainstreaming being implemented for, it started in 2011 for nearly 2 decades, there's still gaps in providing the interlinked services. On this backdrop, the National Nutrition Service, with support from UNICEF and FHI 360, successfully introduced and tested a community-based engagement strategy, we call it CBE, from hereafter, to strengthen integrated mycin and PHC service during 2022 and 2023. And James P. Grant School of Public Health was technical partner to evaluate this approach. The evaluation was done using a mixed methodology, but today I'm going to share only part of this evaluation. The CBE approach aim to, rather than creating new platforms, it aimed to strengthen the existing community-based platforms of the government, like the home visits, quartered meetings, satellite clinics, community clinics, and GMP outreach. As mentioned, the package did not create any new platform or did not hire any new cadre for service provision. While the theoretical strength of this integrated approach was recognized at a very high level, and it was recommended in the midterm sector review of the health sector program, that this integrated approach should be implemented, but the process of this integration was not well understood. Based on this backdrop, we aim to explore the barriers and facilitators affecting the delivery of integrated mycin and PHC services in rural Bangladesh. And we primarily focused on intervention design, the outer setting, the inner setting, the implementation process, and the capacity of the service providers. Before going into detail of the study methodology, just let me give you a very brief overview of the health system of Bangladesh. In rural context, we run a pluralistic health system in Bangladesh with 2 directorates, Director of Health and Directorate of Family Planning, and both have different cadre, different service delivery points, and different processes. At the primary level, we have Upazila Health Complex, Union Subcenter, Community Welfare Center, Community Clinic, and Satellite Clinics. And community healthcare provider and health assistants who belong to Directorate of Health. They provide services. CHCP or community healthcare provider, they are stationed at the community clinic. And health assistants, they are primarily responsible for EPI services, and also they support CHCP at the community clinic. Under Director DG Family Planning, we have Family Welfare Assistant and Family Welfare Visitors. Very briefly about the CBE package itself. So it had 4 main elements. Streamlining of the services, as I mentioned, no new platforms were created. And one big push was integrating a well-child growth monitoring system into the EPI platform. Because the idea was that for EPI, the children come to the service delivery point for certain times. So during those visits, GMP was conducted. That was one innovation of this study. The supervision, the existing supervision was strengthened. The project developed several guidelines, tools to strengthen the supportive supervision mechanism. The existing community accountability mechanism were strengthened, like the community groups or the union parishad. They were strengthened and were involved in this approach to improve community service utilization and community mobilization. The big chunk of the intervention was developing tools and protocols for community health workers. 28 job aids and protocols were developed. One new mother-child health and nutrition card, MCHN card, was developed, but it was not anything new. No new messages were created. It was just compiled all the existing information on ANC, PNC, EPI, GMP into one booklet. It was like a booklet. As I mentioned before, the study was mixed method, and the main findings has already been published. Today, I'll share the findings of the qualitative study. The quality was done in 2 geographical locations. 2 rounds of data were collected during May to June and December to January, between 2023 and 24. Key informant interviews, in-depth interviews, and direct observations were done. And 135 interviews were done. And we used consolidated framework for implementation research to analyze and interpret the data. The high-level coordination or outer setting, our technical interest group was established, and there was very strong partnership support from UNICEF and FHI 360, and the vertical coordination within the operational plans were very active. But on the downside, although there's this technical working group, but the working group did not meet on a regular basis, and mostly informal meetings were used. And we had this inherent challenge of lack of coordination between DG Health and DG FP, and there was also low engagement from the local government. The intervention characteristics, we used the existing platform, which was the strength or the power of this integration. The introduction of this MCHN card, which gives all the information in one booklet. So it was easy for the community health workers or the mothers to understand and discuss the issues. And also for supervision, the study introduced simplified tools for supportive supervision and monitoring. On the barriers, the MCHN card needed a lot of information to be included, which was a burden on the providers. Capacity of the providers, providers were very motivated, and as time went by, the providers increasingly used the tools, which we found less in our early assessment. However, there was only one training session for the providers, which was perceived inadequate, and high workload of the providers were reported. Okay. So can I get one or two? Okay. No worries. No. Thank you very much.
Thanks very much, Santia. And I'm sure if there are any questions that you want to clarify at the end, people can ask you more about your results. I'd next like to invite Santosh Kumar Chowdhury from the Institute for Global Health to come up onto the podium. He's going to present for us a presentation on the evaluation of a school and community-based intervention to promote iodine consumption and healthy eating practices among women and adolescents. Welcome, Santosh.
Thank you. So, good afternoon, everyone. My name is Santosh Kumar Chaudhary from the Institute for Global Development. Today, I will be presenting findings from our evaluation of a multi-state program designed to improve iodine consumption and healthy eating practices among adolescents and women. The study was conducted in collaboration with ITC Foods Division. In today's presentation, I will briefly walk you through the intervention, the method we used, and the key findings, and finally share what this means for program scale-up and policy. Let's begin. Before we go into the intervention, let's first look at the why. Iodine deficiency disorder continues to be a major public health problem in India. More than 200 million people remain at risk. Over 70 million people already suffer from goiter and other iodine-related disorders. These numbers represent real challenge. Children struggling to learn, adolescents dealing with impaired growth, and women facing higher vulnerabilities during pregnancy. Our study aimed to evaluate whether a targeted intervention can improve awareness and practices that helps reduce IDD risk. The intervention had two clear objectives. First, to improve awareness of IDD, what it is, why it matters, and how iodide salt play a role. Second, to promote healthier eating practices, especially among the most influential in household. Our target groups were women aged 18 to 49 and adolescent aged 10 to 17. And the program was implemented across Karnataka, Andhra Pradesh, and Telangana. We designed a robust methodology to assess impact. To measure effectiveness, we used a cross-sectional mixed method design with a baseline and an end line. The study covered 15 districts selected to represent varied geographics and population types. We used a multi-stage random sampling techniques, ensuring that response truly represented through their community and the settings. We measured change in knowledge, practice, and attitude. This approach allowed us to understand not just what people know, but how they think and what they actually do. The intervention was intentionally intentionally diverse because learning styles vary across communities. So we used four major approaches. First, school-based program, engaging adolescents through interactive sessions, games, and demonstrations. Second, community education session, reaching mothers, households, and SHG groups. Third, traditional folk performance, using local art form to deliver messages in a way people easily remember. Fourth, training of frontline workers, ensuring ASA and Anganwadi workers were well equipped to reinforce key messages. This multi-pronged approach ensured repeated exposure, which is essential for behavioral change. Across baseline and endline, we surveyed 2,962 participants at baseline and 2,868 participants at endline. The composition was consistent 50% women, 25% girl, and 25% boys. To understand the impact, we applied linear regression analysis, adjusting four factors such as age, education, ration card status, and socioeconomic status. Our scale for knowledge and attitude had a strong reliability score of 0.8, which validated the robustness of our findings. The results were very encouraging. We saw a statistically significant increase in knowledge score and positive attitude scores. What is important is that these improvements remained significant even after controlling for demographic and socio-economic differences, meaning the intervention worked across different type of households regardless of wealth, age, and education. But knowledge is only first step. Did people change their behaviors? And the answer is yes. We observed important shifts. First, dietary diversity improved significantly. People began consuming a wider variety of food groups. Secondly, overall salt consumption increased slightly by 1%, a small but positive trend. But the most important change was in iodized salt practices. More people started iodized salt properly, more used it appropriately during cooking, and more households constantly purchased iodized salt. These are small but meaningful change that over time reduce the risk of IDD in communities. Taken together, these findings show that the intervention not only improved knowledge and attitude but successfully translated this understanding into healthy behaviors. The evaluation demonstrated that simple, culturally rooted, community led activities can deliver measurable impact. The model has strong potential for scale up, especially in states where IDD remains a persistent challenge. We also see significant opportunity for partnership with academia for deeper operational research on Anganwadi center and frontline workers' capacity. With government departments, especially health and WCD, to integrate these messages into ongoing national programs like POSHAN and school health initiatives. Scaling the model over a longer duration can strengthen behavior change and help reduce IDD related health burden over the coming years. To conclude this, uh, this evaluation highlighted that simple, culturally rooted, and community driven intervention can create real change. Grateful to the organizers for their support and to the scientific committee for selecting our study for this prestigious conference. Thank you very much to all our co-authors for their contribution and everyone here for your time and listening. Thank you very much.
Thank you, Mr. Santosh. It's very insightful, and it's very good to know that at least the intervention worked, and it's also that the knowledge was applied in terms of behavior change, which is often very difficult to do. So the next presentation is by Mr. Satyanarayan Kumbhakar. He is from Institute of Public Health by Bengaluru. Mr. Satyanarayan will be presenting on strengthening ICDS for maternal health, scaling nutrition and chronic disease interventions for lactating and pregnant mothers in India. Thank you.
So, hello, good afternoon, all dignitaries. I'm going to present our research study, which is entitled by Strengthening ICDS for Maternal Health and Scaling Nutrition and Chronic Disease Intervention for Lactating and Pregnant Mother in India. So, co-authored by Professor Pinaki Das and SKMD Abul Bashar. So, everyone knows the maternal health remains a major public health concern in India, and it's a contributing adverse health outcome for both mother and children, and despite improvement in poverty reduction and health service. So everyone knows the ICDS as a scheme such as the multi-dimensional aspect. Those are provide the supplementary nutrition, health checkup, and counseling through the Anganwadi center, especially the benefits the vulnerable group and such as the rural and STs and SC and also economic weaker section. And everyone knows the maternal health outcome such as the anemia, BMI, the high blood sugar as very important factors which are required more deeper empirical evaluations despite the decades of ICDS implementation. So objective of our study is there is two different aspects. So first is impact assessment to evaluate the impact of ICDS beneficiary on the maternal health outcome, including anemia, high blood sugar, underweight, overweight among the pregnant and lactating mother in India. And second one is the generate the policy relevance evidence that can be support the scaling effect of nutritional sensitive health intervention across states. So this is the research content which the based on the evidence-based research and adding value of our research and implementing of all health available evidence to strengthening the ICDS and impact on maternal health outcomes. So the database is we are used from the National Family Health Survey unit level data, which is in fifth round 2019-21. The four factors are the already I mentioned it: the high blood sugar, anemia, underweight, and overweight. So these are the study methodologies for maternal health status. So we used to estimate the maternal chronic health indicators and ICDS beneficiary levels. And for impact assessment, we use the propensity score matching estimation. And after that, we estimate the logistic regression model for the robustness test of our data. And also we check the socioeconomic influence, how effect on the maternal health outcomes. So this is the propensity score matching methodologies which we test the average treatment effect and average treatment effect on treated group and average treatment effect on untreated group, and the side by side the logistic regression model. So this is the result section with the percentage share of the pregnant and lactating mother receive ICD's beneficiary across demographic factors. So here is we found out that the ICD's beneficiary increased from 53.9% to 70%, showing the strong program expansion. And in case of the rural-urban construct, the rural coverage rose sharply, so 59.9 to 75%, and urban gain were the moderate way. So and the caste-wise is in SC and ST is a major increase, and also the slightly improved for OBC category. So now this is the state level scenario. There is also we found the widely the significant variation across whole state, where the top performing state, which is the Odisha, is a 92.7, followed by the Madhya Pradesh and Karnataka achieving the highest coverage during the 2019-21. And the moderate improvement is a state like Chandigarh and West Bengal recorded notable growth in beneficiary coverage. And the persisting the regional gap, the Arunachal Pradesh, Manipur, Punjab remain the lowest high and highlights the need for targeted intervention in the northeastern and several northeastern states. So in this slide we presenting the ICDS beneficiary and non-beneficiary. That means the treated group and control group variation, where here we find out the ICDS non-beneficiary. There's a control group generally have a higher underweight prevalence, such as the Jharkhand, and through expansion the exists showing uneven nutritional improvement in state like Kerala, Tamil Nadu, and Tamil Nadu. It is quite vary from 49.5 to 39.8 for non-beneficiary. So the higher overweight prevalence suggests the ICDS support higher whether weight the outcome. So now we are going to the covariance balance test for before and after matching. This is a part of the propensity score matching estimations. So here we easily this result shows that the matching sample is highly comparable and stratifying the balancing propensity estimation, and the substantial reduction in the bias confirm the observable difference between the beneficiary of and non-beneficiary were effectively controlled for. So now moving forward, this is the propensity distribution graph, which is representing before matching and after matching. So this is the second part of PHM estimation, which is reflect that the treated mother constantly display higher propensity score initially, indicating the greater ICDS beneficiary among the socioeconomic disadvantaged women, and after matching the post-estimation distribution aligning more closely and demonstrating the effective reduction of selection bias through the matching process. So now I'm going to present the four different model of propensity score matching estimation, which is different, like the anemia, high blood sugar, underweight and overweight. And here we observe the significant decrease in the high blood sugar among the ICDS beneficiary, and suggest the modest effectiveness. And where in case of the underweight, strong, the relationship is the strong and significantly improve ICDS beneficiary and reduce the undernutrition. And in case of the overnutrition, it's a very slightly but significant increase over overweight among the treated group, and signaling risks of emerging overnutrition. So now is the major findings that I already mentioned it of our propensity score matching estimation. And after that, when we going to the robustness test for logistic regression model, which is imply the ICDS is significantly reduce the anemia, high blood sugar, and the low BMI among the mother, and confirming a strong positive effect and the maternal health, and but slightly increase in the likelihood of overweight. And in case of the socioeconomic factor, which is the religion and weather matter, and like Muslim mother shows a higher overweight risk, where the middle wealth group shows the greater overweight probably, but the lower risks of anemia and undernutrition. Okay, and the role of education is the higher the maternal education constantly reduce and likelihood of anemia, and low BMI and overweight acts as the factor like the health card, health insurance are significantly lowering the undernutrition risk. So now is the conclusion part. For the ICD's participation significantly improve the maternal health, which is the reduce the anemia, underweight, and high blood sugar among mother. And however, the overweight is rising among the beneficiary, indicating a nutrition transitions, and strong socioeconomic gradient persists, which is the basically educational status, and the economically secure the mother shows the better health outcome, and also support the health insurance and health card further enhance nutritional well-being. So, and in case the policy relevance, the need to diversify and re-imbalance the ICDS food basket to tackle both under and overnutrition and strengthening coverage with Poshan Abhiyan, Ayushman Bharat, and community counseling. And also the digital dashboard of real-time monitoring can enhance accountability. So looking ahead, the achieving maternal nutrition secure is a vital for Viksit Bharat 2047 and a more inclusive, data-driven, and the regional sensitive ICDS can bridge the persistent nutritional divides. So now we're going to the system or the partnership for scale-up, the integrated health, nutrition, and social protection system to enhance the coordinate the efficient delivery of maternal health services. And also, when it comes the standing partnership among the ICDs, as Ministry of Health, local governance, institutions, civil society, and support large scale of implementations. And for enhancing behavior change communications to improve nutrition awareness among the marginalized, low income, and also redefine the scale of ICD's intervention based on evidence tackle both of undernutrition and overnutrition. So thanks to the delivery for nutrition 2025. Thank you.
Just a friendly reminder in the room, I know the presentations are super exciting and we want to chat about it, but we can just save the discussion for the Q&A, please. Thank you.
Thanks very much. Thank you, Satyanarayan. That was very interesting. Could we, I now invite Shri Parna Ghosh Mukherjee to come up to the podium to present on functional integration of nutrition interventions in antenatal package of services in West Bengal, India. Thank you.
A very good afternoon, everybody. It's really hard to present in the last thematic session of a 3-day conference, but I'll try to make it brief. I'll also like to acknowledge my co-author, Dr. Ipshita Bhattacharya, also present in this room, and colleagues from my institution on this particular work. So today I'll be talking about a work that we had done in collaboration with Government of West Bengal from 2018-2022 in 3 different zones of West Bengal in the northern, central, and southern part of the state. The pilot intervention was among around 3,000 pregnant women, of which we had done this study with a smaller figure of 400 pregnant women, 403 pregnant women who were in the intervention group and 406 who were in the control group. The intervention was primarily to promote nutrition during pregnancy in order to address intrauterine growth retardation, low birth weight, and stunting. The results of the intervention was closely shared with Government of West Bengal, which was eventually taken up in the Government of West Bengal portal and upscaled throughout the state. And currently, the policy implications are under discussions with Government of India as well. So out of the interventions, the pregnant women in the intervention block received a certain set of additional interventions over and above the normal RMNCHA package of intervention that Government of India provides. So the additional, in the control block, the interventions, the women received only the standard package of interventions as mandated by the government. But in the intervention block, there were a set of interventions that were additionally provided to these women. The first among them was that at the time of pregnancy registration, while there is a government mandate to take weight and height of the pregnant women, the height is being very sporadically taken. There are lack of equipments to do so across the VHSNDs, and the BMI is absolutely not assessed. So we made it mandatory to assess BMI at the time of pregnancy registration. Next, monthly weight monitoring of pregnant women currently under the government package is mandated only at the 4 ANC contacts. But we made it mandatory to monitor the weight of the pregnant women at the ICDS in every 9 months during the pregnancy period. The third additional intervention was spot feeding of IFA and supplementary nutrition that is being provided to the pregnant women. We were just listening to this mom's plate intervention. We were listening to the ICDS interventions on maternal, the supplementary nutrition during pregnancy. So in West Bengal, the ICDS provides hot cooked meal to the pregnant women. What we made it mandatory was this meal is consumed at the ICDS itself, so there is a supervised intake of the food, and the food is not distributed among family members, and also the supervised intake of IFA at the ICDS centers, so that the IFA is actually consumed, because we all know across India IFA supply is not the problem, the consumption is the actual problem. To mitigate this, we had ensured on-spot intake of supplementary nutrition and IFA. The fourth intervention was a joint visit to the nutritionally rich pregnant women jointly by ASHA and Anganwadi, so that they are adequately being counseled on the effects of gestational weight gain and nutritional and anemia during pregnancy. And finally, the differential nutritional counseling was provided among women of different BMI categories, because as far as we understand, the ASHAs currently are not equipped with differential BMI counseling. They do a flat nutrition counseling during pregnancy. So we had trained the ASHA workers as well as our field workers to do differential nutrition counseling as per BMI of the pregnant women. From the initial pilots, what we had seen, that there has been a significant difference in terms of median gestational weight gain among the intervention and the control groups. In the intervention group, the median weight gain was 9 kgs as against 8 kgs in the comparison group. In terms of gestational weight gain above 9 kgs, in the comparison group it was only 45% as against 52.7% in the intervention group. We had also assessed the gestational weight gain as per BMI, and we had seen that women in the severe thin age group had the highest percentage of weight gain, and we also used the IOM guidelines for gestational weight gain as per differential BMI, and of course the regulated gestational weight gain guidelines was followed among obese women, so gestational weight gain was much controlled among the overweight and obese women. In terms of impact of child nutrition, we also partnered with Johns Hopkins Bloomberg School of Public Health to understand the impact of child nutrition at the end of 2 years of age for the women we were following up. And there has been a significant reduction among stunting, underweight, low birth weight, and exclusive breastfeeding. In terms of stunting, in the intervention group, the children at 2 years of age were 17% stunted as against 32% in the control group. In terms of underweight, only 16% children in the intervention areas were underweight at the age of 2 years as against 33% in the control group. Children with low birth weight was 15% in the intervention area and 19% in the non-intervention area. And in terms of exclusive breastfeeding, we observed 79% infants got breastfed, exclusively breastfed in the intervention area as against 45% in the control area. So I have already spoken about this in the previous slides. In terms of scaling up across the state of West Bengal, we had trained more than 2,500 ANMs across the state and 15,000 plus ASHAs on differential nutrition counseling and BMI, gestational weight gain, and other nutrition risk conditions. The program was rolled out in 2,000 plus sub-centers and 6,500 plus BHSNDs across the state. As I was mentioning in the beginning itself, BMI is not mandatory as part of the government was not mandatory as part of the government portal, which was in advocacy with government of West Bengal, was mandated in the government portal of Matrima, which is equivalent to the Anmol portal that the government of India follows. That was made mandatory in the year 2022, and by virtue of this, all pregnant women who are currently registered in the all state of West Bengal, the BMI is mandatorily being assessed by the public health system. The state level TOT, the programmatic guidelines that we had followed in our pilot areas, that the state level TOT on maternal nutrition has been initiated from February this year and is being currently scaled up in other states as well. We had developed an integrated maternal nutrition program kit which contains job aids for ASHAs and
sure why it's going on. Job aids for ASHAs and ANMs, and a training manual for FLWs, which is being integratedly used by Government of West Bengal in training the frontline worker cadre. Recommendations policy, the slides were jumping to this automatically. This is like very important. We are currently in discussions not only with Government of West Bengal, but also with Government of India, ICMR, and WHO is also framing the global guidelines for gestational weight gain, because as we all know that there are no current gestational weight gain guidelines for pregnant women in India. So there are certain programmatic implications for it. Weighing pregnant women in 4 antenatal contacts that doesn't give enough time for adequate gestational weight gain monitoring. So there has to be a mainstreaming of monthly weight gain monitoring of pregnant women at the ICDS and VHNDs on THR days or days where there's a hot cooked meal that's being provisioned. Prioritizing the monitoring of gestational weight gain. We always observe that the frontline workers take the weight, but it is absolutely not monitored whether the weight is being increasing at a regular basis. So that needs to be prioritized. Malnourished pregnancies are not identified at the time of registration, apart from in terms of anemia and in some places underweight. So identification of malnourished pregnancies in terms of BMI needs to be mandated. Referral of malnourished pregnancies to PMSMA clinic. This is a clinic held every 9th of every month, mandated by the Government of India. So malnourished pregnancies must be regularly checked here. There is the need to develop country-specific and region-specific guidelines on weight gain, as we are observing that there has been a rising trend of overweight and obesity among all population, and pregnant women are no exception. So there needs to be tailored counseling package and weight gain guidelines to manage overweight and obese pregnancies, and management of severe malnourished pregnancies should be made through supplements through a multi-stakeholder approach by involvement of other departments. So that's it from my end. Thanks to the organizers and thanks to the scientific committee for choosing the paper. Thank you.
So thanks very much to all the speakers for those fantastic presentations. We'd like to now invite the speakers up onto the stage. We're just getting the chairs organised. If you'd like to come up and sit down on the stage, then we'll manage a round of questions. And we've got, let me just see the time. It says only 7 minutes left. So that's right, Julie, or is that 7 minutes? Okay, well, that means we've got 15 minutes for questions, so that's fine. Great. Please come up, all the speakers. Thank you. So if you have a question that you'd like to ask, perhaps you could come up to the stand there, and we'll take a round of 2 or 3 questions to start with, and then carry on. Thank you.
Thank you. This is Dr. Afsana from Helen Clay International, Bangladesh. This is Dr. Afsana from Helen Clay International, Bangladesh. My 2 questions to 2 presenter. First one to Santhia Irene, that you have mentioned IYCF was integrated with the primary health care. So I just want to know what component was integrated with the primary health care. And for the community health workers, you have made 28 new job aid. And the year after year, they are using the same things. So suddenly, adherence with these new job aids and new overburden, did you evaluate during evaluation what was the adherence from the community health workers, and at the beginning, what was the changes to motivate them to accept those changes? And to Shantosh, you have, actually I just want to know that what was the intervention you have done at the school level. From the pictures, it seems that you are providing a supplement, so I just want to know more about it. And you have also mentioned that there was a dietary diversity increase. So only with the IDD intervention, actually, how dietary diversity was improved. Thank you so much.
Thank you.
Hello. So thank you so much to the all presenters and the chairs. Myself Bigyan Subedi, MPH from Nepal. So my questions goes to Rajni Om Prakash Wadhwa about the mom plate. So considering the similar problems between the India and in the Nepal, so I was quite amazed by the reduction in the prevalence of the anemia and other nutritional problems through the mom's plate interventions. So you have mentioned also that it is scalable and feasible to the implement. So have you done any cost analysis, or will you recommend any cost analysis to scale up those kinds of intervention, not only in the rural area but also in the urban area as well, because the utilization of the local foods will be in the different, and the intervention modality will be different in the urban and the rural area. So another questions will be the, so how do you suggest to the implementation at the national wide scale level, not just at the particular district level but to the whole level? Will we have to consider different kinds of the intervention as or not? So thank you so much.
Thank you.